Well, welcome everyone, and thank you for joining us this afternoon for the International Comparison of Quality Improvement Training in Establishing Quality and Safety Culture. My name is Lucy Savitz, and I'm the Director of Research and Education in the Intermountain Healthcare Institute for Healthcare Improvement. And on the panel today, we have a group of esteemed colleagues. I'm not going to introduce them individually now. We'd like to reserve as much time as possible for discussion. On the website, there are biographical sketches posted for each of the speakers. As they speak, they'll introduce themselves and their organization that they're representing. Also, on the website is a handout. It's a matrix handout that provides detailed comparison and contrast against the 5 programs that you'll be hearing about today. We've also posted our learning objectives, which I won't go over now, but the real reason for looking at a cross-national comparison of quality improvement training is to try and understand the role of quality improvement training in the organizations. Why did it get started? And what were the issues related to the capacity and resources in these organizations? And what could you learn from these experiences in terms of accelerating implementation in your own organizations? There are really 2 key aspects that you'll see emerge in the descriptions today. One is the role of quality improvement training in driving system-level change, and secondarily, helping moving an organization across a continuum from almost exclusive quality assurance perspective into a more quality improvement perspective as we get to a level of depth and breadth of training in the organizations. So as we compare and contrast across the various programs that we'll look at today, one of the things that you'll see emerge is we're moving from those programs that are very early on in a planning stage using Rogers' diffusion of innovation and all the way out to a sort of routinized or institutionalized level of implementation where they've really been embedded into the very fabric of the organization. You'll also see as we look across the programs, each of these programs has a layered approach to training, that they're training different levels of people within the organization, and then we'll try and call out for you some of the variations in the delivery that accommodate the different needs of the organizations and the different capacities of those organizations. The real generalized approach is the acceptance of quality and safety as a core business strategy, and the sort of belief that learning is the key to improvement, that improvement must be both top-down and bottom-up in the organization, and that the training needs to be both broad and deep for it to really take hold and for people to actually operationalize the tools and concepts that they're given in the training modality, and that the training will really drive that culture change through a common language, through a shared vision, and through the foundational skills and tools that are made available on a wide-scale basis. And then underlying all of that is the need for information systems that provide feedback to those people in the organizations who are really doing the work. So I will stop there, and I'm going to turn it over to my colleague Elise Teil, who will continue. Thank you.
Good afternoon, everyone. I'm Elise Teil. I'm professor in management at Aix-Marseille University recently, and I was in the University of Lyon until last December. I'm here because I'm a coordinator. I am right now a coordinator, and I used to be a coordinator of a master degrees program tailored for CEOs, executive managers, doctors, physicians, and head nurses. And I've been working with Hospices Civils de Lyon, the public hospitals of Lyon, on these issues of training program. Hospices Civils de Lyon is a big public system composed of around 19 hospitals. with 5,400 beds in outpatient places and 19 medical departments. We have 1.4 million hospitalization days, including long stays, and over 145,000 outpatient visits. It's a big system with, as you can imagine, complex issues, complex training issues, because among the 23,000 professionals, all of them are following different training programs inside the structure, but also outside the structure. That's what I'm going to explain to you, the overview of the HCL, so Hospice Civil de Lyon Quality and Safety Management Training Program. Talking about quality and safety management training program for the HCL, when I looked at that, I saw only one training program specifically oriented on quality and safety issues, and that's the internal program of 5 days on risk management. You can see here at medical and quality officers level. So the quality and safety training programs are done among different, outside management program, which are in France masters, because since the new regulation, the CEOs and the chief of medical department and the head nurses must have a master degree. So we will find all the quality and safety training program within those master degrees. So little by little, we see this what we call the masterization developed, and more quality and safety courses within developed too. So at the executive officers, we have this Master of Business Administration tailored. Most of the time they are done within business school, like the main business school we have in France, like HEC and ESSEC. And associated with their professional public schools they have to follow in l'École de Rennes, the Haute École en Santé Publique de Rennes. For the medical officers, it's voluntary. For them, again, the business schools and the universities are offering like what we could call the Master in Health Administration, tailored again according to their own issues, and added to that we have the internal program of 5 days on risk and management delivered by the Hospice Civil de Lyon, by the public hospital itself. For the quality officer, they can have already a Master of Quality and Safety when they arrive in the hospital, or they can follow it while they're already employed by the hospitals. And they follow also the program of 5 days on risk management. For the middle management, the heterogeneity is even bigger, because they can have followed degrees in professional public schools, that we can assimilate to bachelor degrees, or at the university. And now they tend to have Master in Health Administration. For the front line, this is not formal degrees or formal certification for the front line. We have annual seminars provided by the Hospice Civil de Lyon, and then a different short-term training program they can follow inside the structure. But here again, the institution is giving a list of training program they offer, and then the health professional are choosing among them in a voluntary way. So the main issues of the public hospitals in Lyon, first, are the lack of organizational impact assessment that prevent from improvement. First, the institution doesn't really know how effective the training program are and which return on investment they provide. Second, added to that, the professionals themselves say that there is a discrepancy between what they learn in the master degrees, in their training program, and what they can actually really implement when they come back into their hospital. And because they say not everyone has the same tools, then the same culture, not everyone followed the same training program. So we follow a program for head nurses when we are head nurses, and we follow a program for physicians when we are physicians. But when we start working, when we come back into our service and health unit and start working together, we realize that it's not homogeneous, and we don't necessarily have the same language. Even if we all follow the management, quality and safety management program, because it's not going to be taught by the same teachers, and it's not the same networks at all. We can see also, another issue is a rupture between administrative and professional training programs, leading to a lack of integration within administrative and health professional tools. We see like a barrier between the administration and the professionals too. So there is a barrier between different professionals, nurses, physicians, but there are barriers also between the administration that is following specific training program and the health professionals that are following other specific training program. And here again, there is a problem of integration of all this knowledge around the service provided for the patient. Quality and safety improvement tools, the same, we turn around the same issues, are not appropriated largely enough at the institutional level and in an unequal manner, because resulting from that, sometimes for the institution it seems a little bit has a random the reason why it works somewhere in some unit and why it doesn't work in some other unit. And they don't even know why. Sometimes the team make it and sometimes another team won't make it with the same training program for the same partner of the team. So the institution, the public hospital in Lyon, are experimenting a new form of training program to complement. It's not to substitute, but it's to find a way to gather all what, because they want to keep this system where everyone can get trained in a voluntary way, in different master degrees, in different professional certification, in different French schools. But they try to find a way how to gather and to integrate all that within the front line, in the daily fabric of medicine, as Cazenjean said. So the vision is really integration of knowledge and competencies in the daily fabric of medicine, integration of administrative and professional activities around the training program, and a collective decision-making process on organizational improvement levers, with, of course, an assessment of the return on investment of these training programs. So the strategy is to combine external and internal training program. So for internal programs, they experiment in collective and individual practices in small units. So we have the case of undernutrition program, the undernutrition program, which is really transversal and has to touch every health professional. The 23,000 health professionals has to appropriate the issue of undernutrition. So they got training programs, they followed training programs on that issues. And now what they do, they experimented new practices, new management, and new quality and safety tools in 7 units that they coached, I don't know if I can say that they follow really closely with the physicians, the nurse team, and other health professionals associated. And based on that, they started the dissemination strategy, where then the complete team with physicians and the other health professionals are going to are doing the training program for then another team for the next unit. So they go and then they train the next unit to their new tools. So it's a team training program. So it's for team in situ, in their working condition, made by another team of the same institution. And added to that, there are also peer training program. So, and within that, then the physicians work with the other physicians of other teams, and then the head nurses with the head nurses of other healthcare unit. The institution then, to create incentives for that and for it to work, define dedicated time of teacher teams, try to support this and try to value this experiment and this activity of training, and it becomes part of health professionals, part of their time that they teach to other teams their experiment. Excuse me. So I'm done. I'm sorry, I got surprised. Just to conclude in 30 seconds, I'm sorry, I got surprised because my own fault. This really, for the public hospital in Lyon, this really an issue of how we can, from all these fragmented training program, how we can really gather them and integrate all these acquired knowledge and skills that experimented, like in laboratories on case study with professionals, and how to make it really real and implement it in the daily fabric. Thank you very much.
Thank you. We have time for one quick question while we switch speakers. Anthony, would you like to come up to the podium? Any questions for Elise? And we'll have time at the end for discussion. But are there any questions of clarification right now? Thank you.
Hi, my name is Anthony Staines. I run patient safety improvement collaboratives for a group of hospitals in Switzerland. I lecture at the University of Lyon on a very part-time basis, and I'm the vice chairman of the accreditation body for hospitals in Switzerland, Sanacert. So what I would like to share with you today is the experience of one group of hospitals, Fédération des Hôpitaux vaudois, on setting up patient safety officer education. These are a few pictures from these 12 hospitals that are members of Fédération des Hôpitaux vaudois, and we are in the western part of Switzerland, Canton de Vaud, which is in red here on the picture. So the Federation of 12 hospitals. The hospitals are all private but subsidized by the state. The health is run by the counties in Switzerland. And all of these hospitals agreed to launch a patient safety improvement program in 2008. The goal was to have a critical mass for the program, for the education program, but also to control the philosophy of the program to make sure that it was aligned with the goals of the improvement program. So we're here talking of two programs, the education program that has to be aligned with the improvement program. Each of the hospitals appointed a patient safety director, and all of them together had a patient safety program leader within the federation. And the Federation issued a call for bids amongst different education organizations, and the bidding process was won by a joint venture of Geneva University Hospital and the University Hospital of Canton de Vaud in Lausanne. So what was set up as the program, the ambition was to have a program over 6 days, 3 evenings, plus the completion of a project for each of the participants. The audience is 90% internal to these three organizations that have gathered for this program, the Federation of Hospitals of Canton de Vaud, University Hospitals of Geneva, and the University Hospital of Canton de Vaud. 100% of the people targeted were from middle management, and 80% of them were clinicians. The goals of the program was to help to make patient safety systematic and system-wide within the organizations, and to move from quality assurance to quality improvement, to bring clinical quality, or to bring quality improvement into the core business, which is the clinical activity. The idea was a cascading concept, training the patient safety officers, who in turn would train people in-house on some of the issues. The future of the program, it has run twice already, this program. There have been 2 promotions. The future target audience is likely to evolve and to include also senior executives that are in charge of patient safety, or that have the patient safety officer under their supervision. So, for instance, chief medical officers or chief nursing officers, for instance. There is not yet any assessment of impact. The program is probably too young for that, except from participant satisfaction that is assessed. So in the grid that you saw before, where this program stands is here, and I've stated the goals already. The content of the program you can see here at the moment. I won't read all of it, but perhaps just a few items, like the prevalence of harm, definitions of patient safety, the phenomenon of error, human factors, the constructive management of incidents, teamwork, simulation, prospective risk management, safety culture, leadership for patient safety, evidence-based design, patient involvement, etc. These are the type of issues that are included in the program. Now, what I want to emphasize is from this experience, we are starting to build a vision of what a quality improvement education concept should look like. And here are a few thoughts about this. First of all, we think that the curriculum should be tightly linked to the target institution's specific goals. And I think this connects to what Alice Teil has just mentioned. It should also draw from internationally recognized curricula, like, for instance, the WHO patient safety curriculum. There should be a cascading concept of education on quality and safety issues from the board of trustees to the bedside clinician. The education program should include blended learnings, including readings, e-learning, formal teaching, case studies, individual project with coaching, group work, as different ways of learning. The quality improvement work is to be supported by the internal research program, so it should be linked to the research that is done internally, both clinical research and patient safety research. Clinical students should be involved in quality improvement, and there should be an alignment between the education concept and the improvement strategy, and also integration with national pre-graduate and postgraduate education. So the final slide is to try to summarize what I just said with an illustration. And what you have here is the core. That is the cascading concept of education from the board of trustees through senior executives, middle management to the bedside clinician. And then you can see levers. And so, for instance, clinical research, when you press here, it should lift this part here on this illustration. And so clinical research should be used as a support of quality improvement education. And quality improvement education should be nourished by what is done here, and also with quality and safety research, which both imply physician involvement. Another lever is the external education. This is the part that is internal to the to the institution we're talking about. Now, the external education, like a master or a doctoral program in quality or safety, should also act as a lever to help push this up and to leverage this. And so should pre-graduate education programs. And now that's not all. All that should also be leveraged by culture, a learning culture, a culture of improvement in the institution, a culture of evidence-based decision-making, be it in clinical decisions or in managerial decisions, a culture of research, a questioning culture, a culture where you're never satisfied with where you are, but where you always learn and raise questions. And for that, we believe that student involvement is key. Having also an improvement support institute can feed into the education program, skilled librarian support for students and for the whole concept. I have to give credit for what is on here. I've been very inspired by a couple of visits to Jönköping County Council and also to Intermountain Healthcare. And what is on this slide is really the vision that we are coming to now, but really with the help of those institutions. Thank you very much.
We have a clarifying question for Anthony before we move on to our next speaker. Gael? Any clarifications? Thank you.
Welcome to all. It's a pleasure for me to describe you in the next 10 minutes our quality training program project. I am Gaëlle Choupé-Dessart. I am pharmacist by training. I am the project leader for this implementation of a new quality training program. Our director of quality and safety had to done this presentation before, but for emergency family, he won't be here today and he apologized. So I will try to tell you the story of this project. And first, I apologize for my English, and I thank you for your comprehension. Geneva University Hospital is the first group in Switzerland in terms of activity. It's an academic hospital. It's about 2,000 beds and about 10,000 employees. In our hospital, I have to say, there are 12 medical departments and 1 logistic and 1 administrative department. Our way for quality improvement began about 15 years ago, and with implementing a new organization of quality and safety improvement, and with implementing a safety program to manage adverse events. This new organization supported and supports quality projects for the teams on the front line. In addition, some activities focusing quality were implemented in some departments and in institutional level. So, as you can see, there are a lot of things in process, a lot of key points, pre-existing programs, early adopters, executive committee support, and QI project existing. In 2010, there was a strategic plan was decided for 5 years, and in which you can find a quality program with 7 quality projects. 3 of these projects are this one, that was to implement a network of quality officers, so a new job in our hospital. to develop new indicators for dashboards, and to implement a new institutional quality training program. So, when we began this project, we had a stretch goal. It was to put strategic line and front line in the same way of comprehension, and as Alice said before, it was first on common language and common tools. And to reach this goal, our challenge was to imagine a design which permit to reach this goal and to reach all our employees. Another challenge is to determine kinds of training by adequacy between target audience, needs and objective, and disponibility of participants. And the third one is to develop a multidisciplinarity participation. As Alice said before, it is a big problem to make professional culture, different professional culture working together. And our goal is to make different professional culture to learn to learn first together. So, our vision was to develop a modular and flexible design with appropriation and accountability by the leadership, with a program which is adaptable to institutional strategic objective, which is embedded in transparent in workflow. We have the same problem like in Lyon. People are going in training, but when they come back in the work daily, they can't use what they learned before in training program. The knowledge has to be quickly useful after the training program. There is a willing to have easy and accessible continuous learning. We want to reach all our employees quickly and not in 20 years. It's important. The consistency of content and not fragmented contents. We want to develop a sort of recognition for our employees who come to training. And our training program had to be intensive and attractive. So, as you can see, we will try to reach all our levels in our organization. The first training we done 2 months ago was for quality officers, this new job in our hospital, and it was a workshop, 5-day workshop, was be done for all of them. We want to reach the executive committee and using existing annual seminar to do that with external teachers or participants who can come to talk about new way in quality improvement. We want to reach the management committee. Management committee are as committee who are on the top of each department. So there are 14 management committees. The middle management and the front line, effectively, is our stretch goal. To reach the front line, we want to develop a QI boot camp way to make people meet frequently and to share experiences together, and to develop a quality improvement training cafeteria plan, a modular and flexible system. And it's a challenge because it's new for an organization like us, but if we can reach this goal, it would be a real success to make frontline use quickly the knowledge, and to make frontline come in training very easy. Our formats are very different. To make this project, we use our existing program in the institution, and we will to change it, to adapt it to our willing of Cafeteria Plan. We use external program with the university here, and we benchmark another hospital too, and we learned a lot from Intermountain healthcare about ATP training program for quality. So we will develop such for quality officer and for management committee workshops like in Intermountain. And it's we continue. So we develop our program in and the contents of the program in links in regarding to the expectation for each level of our organization. What will be the resources to finance this program? So we have a chance in Genève. We have got a lot of leveraging existing resources because we have a quality department, and as we are a teaching hospital, a lot of senior people, a lot of senior staff is useful making training. So we have the human resources inside. So to summarize what I tried to explain, we will develop a multi-focus offer based on a website with a glossary for common language, tools box, existing project to share experience, a continuous training program with quality boot camps, quality days, and so, a training framework with a cafeteria plan, and workshops and using existing retreat of board to strengthen the leadership. We will do that's it is our internal offer, but there are some external programs in Switzerland. So one of them is the pre-existing program you heard from Anthony Stens. There is a university diploma too, so we will make links between all of that. Thank you.
Max, can I invite you to come to the stage, and any clarifying questions for Gael?
Yes.
Anthony.
Can you comment on what is a cafeteria plan? I'm not sure I understood that.
A cafeteria plan is a kind of framework. I don't have the DR here, the slide here. It's a kind of framework which is very modular, and you can, for each topic, you have different levels of participant, different levels in terms of comprehension, levels for the front line, level for the middle management, and level for the executive committee, so and the directors. And for each program, you can you have an example is for process management. So you have for a front line 3 levels of knowledge which are identified, and so 3 modules for the front line for process management. And the aim is that when people come in level 1, and it can grow up in other levels. And so for different topic, and it's like a trip in a framework, and people can choose when he needs a training, a particular training, he can choose the level, the topic, and so on.
Thank you. We're very good at time. Take a minute to talk to your neighbor. We are in good time.
You are not ready for that, so I start. My name is Bojestig. I'm Director of Health in the County Council of Jönköping, and this is a picture of one of the towns in the area, and this town is called Jönköping. I have worked, I think, with quality improvement for the last 20 years. So I will give you a picture of how we work with this and how we work with our education. In this county there are 13 municipalities, there are 335,000 inhabitants, there are 3 hospitals, 52 primary care units. That changed last year with 20 new ones, according to a reform in the primary care system. So we got 20 new ones, most of them private. And one of the strategies for us to do this as a system is that they are welcome to be a part of all clinical, all quality improvement education for free. So that's a strategy for us to combine the system. We have 32 dental care centers and about 10,000 employees. We have also a theater and so on, but that's another story. And work a little bit. We are in the south of Sweden. A challenge for us is I think, are and has been these areas. How to take care of the variation in the clinical performance. When we're doing the best of our results, it's really good. But how to secure that we can do that every time? Access has, in our county and the rest of Sweden, been actually quite a problem. I think we share that picture with some of the European countries, and there is happening a lot in that area. So that is one tricky area. The flow, how we do an integrated system, is of course an area. How we work with medication, it's actually for the moment quite tricky because there are coming up some very expensive new drugs, and how to implement them in a good way. Patient safety. If I had been here 15 years ago, I'm not sure I was talking about patient safety. I think that's an interesting observation that nowadays is so important. How it could be that it wasn't before. We have learned a lot about that we need to think about this as a system. And coming up is using patients as a source. Prevention is another very important area. And how we use the small teams in the microsystem and how we allow new thinking. So we can do the new thing and not just do the business process re-engineering. That means that we just do the processes that we are doing today in a better way. Perhaps we need to throw out some of them and find absolutely new ways, because the design of today is not possible to do tomorrow's result. So, and of course money is important. We started, I think, in 1990 to do a very broad quality improvement education for our employees. We run very fast into the business of money. So in the middle of 1995 to 2000, the balanced scorecard was a key for us. Because if we didn't combine, so the management was focused on more things than money, it's almost impossible to do the improvement work. So we needed to educate both the management and all employees that we need to measure the results in more than one perspective. You know, it's money and perhaps access. But we also need measure how is the learning and how is the process management. And I think that's a key behind to put that at the ground. In 2001, we became a member of some experiment around the world that was called Pursuing Perfection. It means that we were not just doing good access, we were asked to how to change the whole system. And therefore we come up with this picture. We thought that if we could do learning and innovation as our strategy, we will change the process, the results of a system. And we started to educate in access. You know that there are a lot of different methods to get good access. So we taught our teams in workshops how to do that, and they went out changing. And we found that there are specific methods that they need to learn for that. And then we set up methods to do cooperation and flow. We have a project that is still running that is called Esther, that is about how we follow a patient from the home to the hospital and home again. And we understood that we need to do other methods than the access method to do that. If you combine teams from different parts of a chain, care chain, you need to use more time to understand each other. If you run too fast into solutions, it will just be broken very fast. So we found new methods to do that, and we are still using them. In the clinical improvement work, we went to Salt Lake City and studied how they do it, and you will listen to that soon. How they work very tight with the clinicians to do new clinical results. And we're still doing that in a lot of themes, because we need to think about how to use our clinical registers, how to use those data, how to have teams with the doctor and nurses to reflect on their results and doing these improvements. Patient safety and medication. And we have recognized that if we do this, we change the system and we will have good finance situation. And this is not a meeting to show the results, but it's possible. In patient safety, we recognize that this is like a jigsaw, or you call it a puzzle. Behind each of these, there are change methods, and we do it more into the ordinary work. We think we could start with this teaching in teams, doing a project. That means that everyone have an own experience that it's possible to do a new result and you could change your circumstances. But now we need to have it into the daily work. So we need to train the teams instead how they could measure their results on a more daily basis and follow it up and change how they do. And then they need to do all these different parts. They can't do it just by project. It needs to come into the daily performance. And that's a little bit different. And in some places this will be called the Toyota production model. So we use a lot of different words for these things. So What we're trying to attack is that we are doing this in different levels. We have leadership programs, all of them, I think we have 4 for the moment, in different levels. All of them are training in clinical improvement and quality improvement and patient safety. We have programs for residents and for students. They also need to do quality improvement project and learn from that and learning the methods. When we meet with the strategic leaders, we do that with all leaders 5 times a year. We use half of the day for clinical improvement and reflection on how we work with it. And we also learned that from the beginning we could do this in our county. But then you need more people to learn from. So we're doing it more and more national. And there is a national emphasis in a lot of questions, and we think that's very good for our learning to come together with others and learn from that. So for instance, in diabetes, we have teams that comes together from the whole country, look at their data using the National Quality Register, how to change it, and then go to the new level. We have just recently, I think it's the 3rd wave, started a master program together with Dartmouth Institute and Professor Bartholden in quality improvement. So we have a regular education in this area. But we're trying to do it to as many of our staff as possible to just get the new result. Thank you.
Any clarifying questions?
Thank you.
So I already introduced myself. I'm Lucy Savitz, and my colleague Pascal Briot would be here to co-present. Unfortunately, he had a family emergency and could not join us today. And what I'm here to present now in the conclusion across all of these different training programs is to talk about what's been done at Intermountain Healthcare. Intermountain Healthcare is located in the state of Utah in the United States, and you see the start area here. Some of you may have visited us. And the work that I'm going to present is really based on the vision and the leadership of Brent James, my boss and a colleague who has been working for over 20 years to bring quality improvement training to Intermountain Healthcare and to a number of training programs across the world now. So Intermountain Healthcare is what we call a fully integrated delivery system. What that means is we have about 23 hospitals. We only employ about 1/3 of our physician workforce. Many people believe the myth that we employ every physician and we just tell the physicians what to do, and that's not true. We have 145 clinics, and largely our healthcare delivery system is spread up and down what's called I-15. It's a highway that goes right directly through the state and is largely geographically bound by the mountains that exist in our state. We also own our own health plan, and we provide care to about 60% of the population in our state, which really gives us a public health perspective in a lot of the decisions that we make about how we deliver health care and how we think about the delivery of health care. And when Brent originally had the vision for the training program, I think a couple of things that are slightly different and have evolved over time are, one, that it should really be modular, that we should always use a train-the-trainer approach. So when someone comes to us to be trained, we give them the tools and resources to go back to their unit, to go back to their department, to go back to their institution and share that learning so that everything's not dependent on coming back to the mothership, if you will. And to really firmly integrate the quality improvement tools and concepts into the workflow. And when we originally put our training programs in place, we had something called clinical integration, and it was an analysis that Brent James and Dave Burton did where they looked at all of the key processes that occurred across the fully integrated delivery system. And they identified really 140 key processes and then clustered that around 9 clinical programs. And we were able to integrate the quality improvement tools and concepts into the very infrastructure and the way business was done in these clinical programs as they were being led by a physician leader, a nurse leader, and a data informaticist who worked together to be able to actually execute on what was being learned. So it was really embedding this into the operational process. We also have learning at multiple levels the same way my other colleagues have described in the organization. And what really gave rise initially to our training programs was something called the Q studies, and they were quality improvement studies. And what Brent and colleagues were able to show were millions of dollars that could be saved in the healthcare delivery system by virtue of doing quality improvement. So it's Deming's core concepts of by doing the right thing, it actually is more efficient. And through that demonstration, the very leadership of the organization said, formalize these programs, make these program offerings available to everybody. And it started out with training of leadership and then moved down through a cascade until what we have now is something called 100% participation. And the idea behind 100% participation is that everybody has to look at their job differently. So 95% of your time is spent doing your job, and 5% of your time is spent looking at your job and figuring out, how do I do my job better? And so that's not just from a leadership perspective, that's from somebody at the front line, whether you're a housekeeper, whether you're a nurse practicing on a unit. Everybody is responsible for looking at their work very differently. And through a variety of training programs, you've heard, I think Elise referenced the advanced training program in quality improvement. That's probably the most robust training program and the one most people are familiar with. And that's where Brent brings in the experts in any particular field. They come to Salt Lake City and they offer that training. It's a break-even training program. We don't look to make money on it. People come from outside the organization. People come from inside the organization. It's a team-based training approach. It's hands-on, so you actually do a project and you apply the tools and concepts as you go. We have a mini ATP program, and the mini ATP program is taught by Brent and other staff, including myself, where we largely cater to our internal audiences, if you will. Again, it's a break-even project, and people are coming from outside of Intermountain now so that they can learn the tools and concepts there. There's a physician's education program. All new physicians at Intermountain Healthcare are actually required to take that training program so that they basically learn the common language, the tools and concepts as they're brought into the organization. And we're starting to see demand for that as well, because we can't keep up with the external demand that we're seeing for the ATP and the mini ATP. And then again, 100% participation is a series of DVDs. They're 5 20-minute DVDs, so that staff across our organization, our very large geographically spread organization, can get training on an as-needed basis, and they can refresh that training as they need to. And so I've sort of talked through all of these different training programs at the various levels. We don't require that somebody has a certain degree to attend a certain level. We don't restrict attendance. So for instance, we commingle physicians, nurses, pharmacists, respiratory therapists. Anybody can come to any of the training programs and learn together, depending on what their project is. And so by virtue of the way the training program is constructed, we're not separating people out into those silos, and we hope that it's really creating the kind of team, non-hierarchical learning experience for people so that they can go back into their clinical settings and apply that learning. The learning is more extensive the higher up you go. So if you look at the advanced training program in quality improvement, that's 5 full days, once a month for an entire week, over a 4-month basis. The mini ATP is 3 days. It's actually 2.5, taught once a week, 1 week per month, over a 4-month basis. And then the physician training program is 2 days, And I've already said the 100% participation is a series of DVDs that people can have access to. The one thing that I will tell you, though, that is intriguing to me, and it was intriguing as we were discussing across the groups, when Matt's told you about the opportunity to save money through doing these projects, and I told you about the very genesis of our training programs, where the CEO of the organization recognized the millions of dollars that could be saved initially. This was 20 years ago. And if you look across that 20-year history at Intermountain, the nature of what defines success has changed. So initially there was a recognition that you could apply Deming's concepts that by doing the right thing you could actually save money in an organization, and we moved away from that, and it became almost exclusively about quality improvement and patient safety. And now in the current environment that we're operating on, people are taking a stronger interest in looking at the efficiency part of that equation again. And I think the challenge for all of us in all of these programs, and I would guess for the programs that you're looking to develop or have developed, that to have a consistent set of measures that let us look across the projects to see what is the level of cost savings, what is the level of quality improvement. It's a real gaping hole, and I think it's a challenge to any of us that are doing quality improvement training to think about how can we assess the impact in a standardized way across these programs so that we know, because of the investment of time and resource that we're making in these training programs, how can we do it better? And are we having the desired impact? So as I've already said, when we think about the resources and financing, ours are break-even projects. We are not looking to make money on any of these training programs, and so they need to be self-sustaining nevertheless. The other thing that I think is unique about the way Brent has thought about this training program, and it's something that's carried over into other activities we do, is that he believes everybody should pay something. You know, as I look across the room, I see a couple of people, you know, looking at their telephones or, you know, doing their email. When you come to a training program at Intermountain, the expectation is you're present and you're there participating actively. And so for us to not be distracted by the work at home, to come away to a place where you can have a safe environment to learn and to really focus on the learning is important. And Brent has found that if you don't pay anything, you don't have that same level of commitment to the training program. And I think that that's something that we've seen over and over again. Again, we've not done a good job of measuring return on investment since those very early days in the training program, and we're looking to that again, and I think as a group it's something that we're thinking about. How do we challenge ourselves to come together and think about it in that way? So basically what you've seen across these training programs is training programs that are starting out really in the planning stages, they're in the early stages of adoption, they're later stages of adoption, and then as you move on to Jönköping and Intermountain Healthcare, programs that have really been around for a long time and been institutionalized. And you've heard a lot of different observations about how people have leveraged different resources in their own communities. When Gael talked about what they're doing in their program, and they're actually leveraging the resources of the local university, which is slightly different than what some of us are doing. For instance, at Intermountain, there is no degree associated with the work that you do, and there's no requirement that you've had any kind of training in coming to that training program. These are all very different adaptations that really meet the needs of the organizations that are sponsoring them, that are driving the quality improvement and housing those improvement efforts. So let me stop there and see, are there questions, are there comments, observations from the audience? We certainly have time for discussion. Yes, ma'am.
I'd like to ask everyone, do you think that commitment from the chief executives in any of your organizations are enough? Because one thing I see is I truly believe as the person has ultimate responsibility, do they truly understand the importance of quality and patient safety? And there's always, I think, an out clause for some executives that they have not had the previous experience, and especially if they haven't had a clinical background, they're relying on other people. And sometimes I think the boat gets missed and the person gets blamed, and I really think it has to be across the board that we share the responsibility for patient and for quality and patient safety. And I think unless everybody's prepared to embrace that, we're never going to get it to where it truly needs to be.
I was looking for the microphone, I didn't get the
So your point is basically the role of leadership being actively involved in embracing the culture and the concepts of moving forward in quality and safety improvement?
Because you pitch it at middle management, so why is it not pitched at the
Yeah.
very top?
So at Intermountain, we started with leadership. And I think, Anthony, your program really focuses on leadership. Is that not correct?
Well, before we set up the patient safety officer course, there was a briefing in all of the board of directors of all of the institutions and the management committees and the physician boards. Brief, of course, but to align the philosophy of. But nevertheless, it's tough. So we tried. I'm not sure we succeeded in all that, but I think the point is really well taken.
Mats, did you want to comment?
That has become a key in our system. So we travel with the whole management team to this conference since a lot of years ago and to the American, and we really go with the whole management team. So that's a key.
I think we have a question.
Thank you very much for those really interesting and informative and slightly varied presentations about how you can achieve this very important aim of getting everybody trained and competent. But my question, I guess, links to what Liam Donaldson posed at lunchtime, which is that if we really believe that improving quality and reducing risk and harm to patients is as important as we think it is now, and more important than it was 15 years ago, at what stage do we make the break with voluntary and agreed participation in these programs and say that, well, it's just like any other part of the regulatory process for healthcare professionals in particular, but also for managers, which is that for many national regulators, you have to do so much professional development, you have to do certain things. Nurses have to complete certain mandatory courses, for example, to re-register every year. So with your experience and everybody else wanting to learn from that, when do you think we move from essentially a supportive and very, but largely voluntary, you had some exceptions, to making competence in quality improvement and an understanding of safety mandatory for people who want to work in healthcare? Because it seems to me that's the kind of point we need to think about.
I would just say from an Intermountain perspective that can't be a mandate of the organization alone. That the mandate, when you start to influence professions, has to come outside of an organization. I mean, we clearly have expectations that everybody in the organization will know what a statistical process control chart is, and they understand the language organizationally. But one of the things that we've seen in the United States is a number of professional societies having requirements annually for recertification for people to do quality improvement projects. And so I think it's that national external drive that's going to really be necessary to make that happen. In the United States, the other thing that's happening is from our payment system, expectations on value-based purchasing. And so the extent to which those national bodies are going to help drive what the organizations are doing, I think that's going to be the fundamental change for professions. And I would just ask my colleagues.
My name is Johan Kaltorp. I'm partly linked to Jönköping University, not Jönköping County Council, but in close connection to County Council. I've also been at Intermountain several times and learned from Anthony Stein. So thank you for this presentation. I think it's a key session in this meeting, as I understand. I mean, the knowledge base for transforming medicine, and I think comment just linked to the earlier speaker. I mean, it's shocking in a way that, for example, in our country, Sweden, you can come from the street to become a health manager if you have the right sort of judged competencies, but you don't have to show certificate of health management training. So I think it's a broader issue than just quality training, but it's sort of that, of course, one aspect. So healthcare has to change, and the managers, of course, linking to the issue about CEOs exactly. I mean, that's a learning from Toyota, as I understand. Those who train the people who do the changes in the process must know the issues. It's totally, you can't, for the future, you can't be a CEO of a health delivery organization if you don't have those skills. So I think this is a big issue for the future. And then just comment the link to research. You said, Lucy, somewhat underplaying Intermountain, as I understand when I visited. I mean, your, or Brent James's shop, as you say, I mean, that's a real research institute, as I understand it. And people are academically linked also, so in essence you have a specific research body that also is very much into the application issue and do training. And that's, by the way, as I understand from Kaiser, from Group Health Cooperative, etc., the integrated system as at the front line in the US has that type of interesting arrangements.
If I may just comment on the question we had just before, I think it's an interesting issue. What should be mandatory in training if we want to, for instance, patient safety to become something really systematic? I must say I'm fairly torn between the two models. I would fully agree that if we want things to be systematic, which we should be able to train each and every one in the organization, and that therefore a good part of the training should become mandatory. On the other hand, I always remember, and I think Brent James quotes that very often, that Deming said, if you want to reach a population of N people with an innovation, you should really convince the square root of N, I think. And so perhaps it's sometimes even more worthwhile to have really well convinced the square root of N than really targeting the N. So I'm a bit torn between these two items. I also see, I do lecture in France, and I have seen the current discussions about the introduction of the checklist in France, as France chose a model to integrate the checklist within the accreditation requirements, which we in Switzerland did not do. So in Switzerland, we're really lagging behind in terms of bringing the checklist to the operating theatre in the whole of Switzerland, and I think France managed that quicker. But on the other hand, are people really convinced, and how do they fill in the checklist? Part of the people do it because it's mandatory, so you don't do it the same way when it's mandatory. And I think now there is a sort of second wave of reintroduction of the checklist that Haute Autorité de Santé is promoting, with crew resource management and with the real sense-making around it. So I really don't have the answer to that, but I see the points, and I think we really need to keep thinking about that and continue to exchange on an international basis.
Yes, just want to add a few comments. I totally agree with Anthony. We know now that when you try to promote a program like from the top level and mandatory, it doesn't have the effect you want. And the issue now is the appropriation. It's a changing process, and we're talking about culture. So the issue is a common culture, and when can we define that we have a common culture? And that's why we start like with a public hospital in Lyon. They already had institutional program and mandatory, you have to follow that and follow that and follow that, and it didn't have the effect they were expected. So they tried now to work from the front with the front line and try to adopt a dissemination strategy. And after a while, the culture is going to be common enough. We don't know if it's the square root, if it's 50%, or when it is, but we really count how many people are involved, how many physicians, how many head nurses have followed this mutual training program. We really work with them. And after a while, we think that we will have we will have go beyond the threshold of the common culture, and it's going to be solid and strong enough then to be able, like, to have this virtuous circle on that.
If I could just pick up on a point that Johan made about the research. It's not something that we really focused on when we were comparing across our programs, but I know Anthony mentioned it in one of his slides, and I actually am the Director of Research and Education at Intermountain. And one of the things that I can tell you that is a national move in the United States, but it's something that we consider very important at Intermountain, is to think about how we do rigorous quality improvement so that it becomes a part of building an evidence base for change. Just because you do an improvement in one unit or one department doesn't mean that you're going to get that same success across an organization or across other organizations that share in those. And so an important aspect of the training is to help people understand why it's important to document and assess and evaluate the work that you're doing so that you can hand it off to the next level of investigation and we can build that evidence base. There's a major initiative in the United States right now that's funded by the Centers for Medicare and Medicaid Innovation, and it's called the Hospital Engagement Network. And we're seeking to improve patient safety in 10 specific areas that all of us have been working on for quite a long time. One of the problems is there's not a lot of evidence base behind the improvement strategies that we have to put in place. And so I think as we all move into the future, we have to think about how do we teach people to be more rigorous in their quality improvement, and how do they share that learning with us within this sort of culture of learning that we're trying to establish in our organizations so that we can build an evidence base. Other questions or comments? Yes, ma'am.
Thanks. Just want to pick up something else that Liam said this morning about hierarchies and sort of the issue about managers. I just wondered if you'd like to sort of reflect on the degree of hierarchies in the management structures, because it does seem to me, I think it's a fascinating sort of presentations, very different places. Do you have a flat management structure? Is it okay for people to say upwards? And it seems to me that it seems to be a really important bit of culture is that, and that is that it is safe for anybody to say to speak truth unto power. And I just wondered in your different institutions how you would describe the hierarchies or lack of them that you have, and whether that contributes to the safety culture and the ability to learn about quality improvement.
I can start. As you can imagine, in Lyon we're talking about public teaching hospital with a big hierarchy and very strong hierarchy. And where we're talking about culture, quality culture, it's also quality culture for the administration. And you raised the important point, which is because the expertise are in different hands. And if we say we need to integrate everyone, we need also to rethink the roles and responsibilities of everyone in the organization. And it means maybe several hierarchies. It means maybe several structures with experts in different domains. And that's the biggest barrier, because it really calls for thinking differently the organigram, so the hierarchy of the structure. And we're talking about lean management and the culture, quality culture, which means everyone has to be able to call someone else and tell, hey, look, there's something wrong in it. And that's not easy in a big hierarchy.
Thank you for that question. I think that when I, instance, do teaching in diabetes, it's the whole team. And I think that has been very effective, because from the beginning they start to think that it's about our knowledge in diabetes that gives the result. And then they look at the figures and they discuss it, and the nurse says one thing and the secretary another thing, and the doctor from the beginning is trying to tell the others how it is, and then recognize that perhaps it's not that way, that you could look at it from different angles. So I think that during these years they have grown and experienced that we got into a much flatter organization and appreciation of the different culture that everyone can come up with an idea, and that's valuable. And you can, when I now look at Britt-Marie here, and you can look at this case of this patient with hemodialysis, and a nurse that was brave enough to support that, and then a management team that could support that around. And I think that has grown from these sort of experiences that we need to learn and test.
So the point I didn't have a lot of time to explain, at Intermountain the answer would be it depends. And I think that's true of any organization. But one of the things that we've done through the clinical program structure, there are 9 clinical program areas. Each of those clinical programs is led by a nurse leader, a physician leader, and a data informaticist. And through work teams that are associated with those clinical programs, they develop care process models. And the care process models provide the structure and the communication mechanism that's possible. So within places where there are strong care process models that have been implemented, it's very easy for people to work outside of the hierarchy. And that's built into the very organizational infrastructure. Clearly, there are places you could go across our organization where you wouldn't be able to do that. But in those areas, and I think that's the important point that was made very early on in this presentation, it's not just having your quality improvement training programs sitting off to the side independent. They need to be integrated into the very infrastructure of the organization. I think we have time for answers.
Perhaps also one other comment about hierarchy. We have issues with hierarchy, and it's difficult to make sure that people would stand up and then bring their own opinion in front of more senior colleagues, etc. The link to the quality education program that our thoughts currently are that we should use more case studies in such education programs. And we've just decided with Pierre Chopard and another colleague to build a case study around a very ambitious hand hygiene program that is starting in one hospital in Switzerland. And that hospital has had a very interesting session to analyze if all the success factors were present to launch its program. And so we would like to build this into the case study so that the participants could, with all of the levels of the hierarchy around the table, discuss are the success factors present and should we launch or should we not launch this. And so that should integrate the patient safety officer program shortly.
Great, thank you. We have time for one more comment. Gael, do you want to comment?
For Geneva, I don't know if you remember, there are 14 departments. At the top of each department, there is an executive committee with a physician, a nurse, a financial people, and human resource people, and the intervention of the quality officer. So that's why, for this question of hierarchy, we want to apply the principle of mini ATP for Intermountain. That means 2 days lecture, 4 times, and making these people working together on a project. So to make them understanding what is quality improvement and what is the impact of working together and understanding together, yes, in a team.
We're at time right now. I apologize. In the handout, you have email addresses from each of the speakers. There's much more information in that matrix that's posted that we didn't have time to go over. And we will be working on a publication of this material. So please join me in thanking the panel. And thank you for coming today.